Assalamu alaikum. Hello and welcome to this first edition of the Neuropathic Pain Management webinar. My name is Gerard Moore and I am the webinar support manager for today. You will be joined by Dr. Ahmed Shatila and Dr. Waleed Khalifa. The webinar is supported by SSMC and SAHA, and we will give our thanks to Pfizer Upjohn for the support of today. The webinar attendees, welcome you all from wherever you are. You will have a chance to ask your questions and comments in the chat bar on your right hand side. Any video or audio issues you can send to me via the admin only button, which is located on the chat bar. You will see a red reconnect button. This is located at the top of your screen. If you have any video or audio issues, you'll be able to click that and it will refresh the slides. I'd like to start by welcoming Dr. Ahmed Shatila to give the formal opening for the Neuropathic Pain Patient webinar series. Dr. Ahmed, the floor is yours.
Thank you, Gerard. Good afternoon, good evening, everyone. First of all, I would like to thank everyone who took time to attend this webinar today. Today it's going to be a two-part webinar. I will be speaking, giving a general introduction to neuropathic pain, and then Dr. Waleed Khalifa, a neurosurgeon at SSMC, he will also be talking about back pain and radiculopathies. I would like to thank, first of all, our sponsors, Pfizer for sponsoring this event. I would like to thank SSMC for hosting the event and Focus Gulf for organizing the event. And finally, last but not least, I'd like to thank every one of the attendees for taking time to listen for this lecture. So without further ado, I'd like to start. There we go. So like I said, I'm Ahmed Shatila. I'm a neurology consultant at SSMC Hospital in Abu Dhabi. And today I'm going to talk about neuropathic pain. So when we look at pain in general, there's two types of pains that we have to consider: nociceptive and neuropathic pain. Now, for nociceptive pain, usually it's considered aching, throbbing, and it's usually well localized. And it's time limited. What does that mean? You know, you cut yourself with a knife, it's nociceptive pain. Usually there's tissue damage, and when the tissue heals, the pain goes away most of the time, but you can rarely get pain after the injuries. And usually it responds to conventional anesthetics or analgesics such as morphine, tramadol, or NSAIDs. Neuropathic pain, on the other hand, are described more as a tingling, shock-like, burning sensation, and patients can also present with numbness. And it can be either one of those symptoms or all of the symptoms. And it's usually almost always a result of a chronic condition, and they do not respond to conventional anesthetics or analgesics, such as NSAIDs, morphine, or even tramadol. They don't respond to those type of medications because the pathophysiology is different. Now, neuropathic pain has a wide variety of etiology. It's not just one disorder that can cause neuropathic pain. Usually, the neuropathic pain is a result of some injury to the nerve, whether it's shingles, diabetic neuropathy, which I will not be talking about in very big details today because there will be another webinar talking just specifically about diabetic neuropathies. Surgeries can, as well as nerve trauma, and radiculopathies can be another etiology, which Dr. Waleed will be talking about in our next lecture. So when we look at pain, first of all, you have the nerve damage. The etiology can be different. You can have a metabolic cause, such as low vitamins or diabetes, ischemic, hereditary, such as hereditary disorders such as Fabry's can cause these type of pains. You can have compression neuropathies from carpal tunnel or ulnar neuropathies. It can be post-traumatic or a result of toxins such as alcohol. Infections, HIV is very well known to cause this type of pains, or it can be immune related. Now, all of these path, all of these triggers can cause a change in the nerve pathway and how the nerve functions, which then will give you different symptoms. You can either have spontaneous pain or stimulus-induced, stimulus-evoked pain, which is characterized as neuropathic pain. Now, how common is it? It's actually pretty common. When you look at different studies looking at neuropathic pain, it can range anywhere from 5 to 20% of the general population. As you can see here, there was over 7 studies that looked at pain in general, and the range was anywhere from 5 to 20% of people complained of neuropathic pain. The conditions that can cause it, I did highlight a little bit of them: diabetes, cancer, HIV, post-surgical, low back pain, post-herpetic neuralgia, strokes, spinal cord injuries, and MS. Now, as a neurologist, we see all of these conditions, but I would say the top 3 that I see in my clinic are usually MS, because I do have a relatively large MS population who do suffer from neuropathic pain. Diabetes is a big culprit. Post-herpetic neuralgia and chronic back pain are a close second. And the range is anywhere. You can have up to 75% of people with neuropathic pain from spinal cord injury. So it's pretty common depending on what the inciting factor it is, or the inciting etiology. Another study, when they looked at the UK, the most common cause of pain or neuropathic pain in this study was back pain, which is in the form of radicular pain radiating from the back to the extremities. But then again, post-herpetic neuralgia, diabetic neuropathy, and phantom limb, which is extremely rare, but we don't see it a lot. But this is usually people who have a limb amputation who still feels their own limb after the limb has been cut off. Now, when we look at pain or neuropathic pain, it's not just the pain that's affecting the person. The pain is causing it has a multifaceted, it affects the patient and on a multifaceted level. What do I mean? It affects their activities of daily living, reduced quality of life, sleep disturbance. As a result of the sleep disturbance, there's a whole host of other disorders that can come because you're not sleeping well. Hypertension, insomnia, you're not focusing. People then have psychological burden, the depression, the anxiety of living with chronic pains. And then you got the disability of the pain. And both of these, both the intensity and the duration of the condition exacerbates the patient's burden, meaning that the longer the patient suffers and the amount of pain he suffers makes his condition worse as the length of time goes on. It's not just the pain that people suffer, as I said. In this study here, when they looked at people who had neuropathic pain, over almost 70% of people with pain had difficulty sleeping. As a result, there was a lack of energy, daytime drowsiness. You're not concentrating as well. Try staying up overnight one night and then see how well you focus. Now imagine this is like every night. Then you got the depression, anxiety, and poor appetite that results from the fact that you are living in chronic pain. So it's not just pain that, I know some people be like, it's just a little bit of tingling or numbness, just toughen up. It's not just like that. That's why pain's it's actually our 5th vital, right? And it not just affects the patient personally, but it actually affects their productivity and their quality of life. In this study, when they asked people, how has their pain affected their work abilities in the past 4 weeks, over 80% of people with neuropathic pain had complained of either a little bit of that the pain affects their work ability a little bit or almost all of the time. Only 20% of people with some type of neuropathic pain said that it did not affect their work. So for the majority of people with neuropathic pain, it not only affects their quality of life, but it also affects their productivity. And this slide was repetition by accident, so just ignore that. When we want to diagnose neuropathic pain, it can be challenging. Why can it be challenging? Because you have multiple complex mechanisms. There's not one mechanism for the nerve injury. The symptoms are very broad, and I'll talk about the symptoms in the next few slides. So people don't come in with the same exact symptoms like migraine. With migraine, they'll tell you, I have a headache on one side, light bothers me, sound bothers me, I have nausea and vomiting, and it's throbbing in nature. It's pretty standard. With neuropathic pain, it's not like that. The symptoms vary, the locations vary, the intensity varies. So you have to really think about outside of the box, and you have to think about neuropathic pain in order to diagnose it. And then finally, one of the other reasons is that it's difficult sometimes for patients to tell you what are the symptoms they're feeling. I'm going to be talking about burning and tingling and paresthesias, but our patients don't tell you, I have hypoesthesia or I have allodynia in my limb. They tell you it hurts. And then it's your job to try to differentiate what exactly do they mean by it hurts. When they asked physicians how hard was it to diagnose neuropathic pain, you can tell that when you have someone with HIV or reflex sympathetic dystrophy, 80% of people had difficulty recognizing that this is due to neuropathic pain. But when you go down to like postherpetic neuralgia, only 20% of physicians or GPs, and even of which 9% of this population were pain specialists, thought it was hard. So the conditions can vary. How you diagnose it also varies, in the sense that some disorders are really easy to diagnose, whether it's postherpetic neuralgia or trigeminal neuralgia, it's maybe easier. But when you go to like HIV, reflex sympathetic dystrophy, or MS, it's not as easy or straightforward. And then when you get to cancer, it's also difficult, because sometimes it's not even the cancer that's causing the pain, it's the medications. So you got to know what meds they're using that's causing this pain. How do you approach people with neuropathic pain? It's the 3 L's. You got to listen to the description of the pains. You got to locate the lesion or the area, and then you got to look for any abnormalities. When we talk about pain as the listening, you want them to tell you the duration, the frequency of the pain, the quality. Is it a burning, an aching, an electric-like, a shock-like pain? The distribution, and then how does it affect your activity in daily living? As I said, these are some symptoms that people may tell you. They may tell you it's burning, it feels like I'm walking on fire, it's tingling, like ants are crawling on my skin. They may describe a shooting pain where, they'll describe this pain that starts from their back or from their elbow down to their hands. It can feel electric, like in trigeminal neuralgia. They usually describe this as if their face got stuck in the electric socket. Or sometimes they just say, nope, I don't have any of these, and it just feels cold or numb. You have to listen. So when we have neuropathic pain, it's broken down into 2 types. You have the positive symptoms and the negative symptoms. The positive symptoms are everything I just described in the previous slide. The burning, the aching, the electricity, the radicular pain. The negative symptoms are actually the lack of symptoms or loss of symptoms. It's the numbness, the coolness, it's the no sensation, which can be characterized as allodynia, hyperalgesia, dysesthesias, or paresthesias, or on the contrary, hypoesthesias, anesthesias, hypoalgesia, and analgesias. A lot of gesias. You want to look for any physical abnormality. You want to inspect the body part that they're complaining that hurts, because you want to see if there's any abnormal rashes, any abnormal vesicles or pustules, or any deformities in that area. And then you want to conduct a simple bedside test to confirm the abnormality, the sensory abnormality. And this is done by using a tuning fork, or you could use a monofilament. Sometimes I just use a tissue paper. You just grab a tissue paper from your desk and you run it up their leg or down their arm, and they can tell you it'll feel different. Distally, it's not as strong, or as proximally. Or with the tuning fork, I just run the tuning fork up their arm. They'll say it feels cold in their elbows, but it doesn't feel as cold in their fingers. Or same thing as their knees to their toes. How do you approach someone with suspected neuropathic pain? The first thing you want to do is you want to listen to the verbal descriptors and the histories. Are they suggestive of neuropathic pain? If they aren't, then you're probably dealing with nociceptive pain. If they are, then you got to detect, is there an abnormality that you can do? Is there a specific nerve that's involved, or is it multiple nerves? If it is, then can you identify the responsible nervous system involvement? Is there a specific lesion that you can attribute to these problems? And if you answer yes to all of these, you probably have neuropathic pain. If you get to this point here and you answer no, it could still be neuropathic pain, and this is where it may be beneficial to send them to a neurologist, a pain specialist, or to have further testing performed. How do we manage neuropathic pain? The management is really multifactorial. There's no one, because the cause is multiple and the symptoms are different. There's no one treatment that will take care of neuropathic pain. So first of all, you want to treat the underlying condition, whether it's your carpal tunnel, you want to wear a wrist brace, whether it's your cancer or your diabetes, you need to figure out what's causing the pain. So you got to treat the underlying condition. You got to treat the comorbidities that they suffer from, and then we can try some pharmacologic or even non-pharmacological treatments to reduce the pain. And by reducing the pain, that's our primary goal. But then you have the secondary goals. You want to improve their quality of life. You want to improve their sleep ability. You want to be able to improve their functioning in society and overall their overall psychological state. The goals. The first goal is you want 50% reduction. You want at least 50% reduction in pain relief. And you have to be realistic. Sometimes patients will come back and they'll say, but I still have pain. And yes, they may have pain, but your question is it better? And if it's better, by how much better is it? 50% or greater is a realistic goal. I mean, if we get 100%, that's great. But we have to be realistic, and we have to tell our patients to be realistic. Because you got to remember, sometimes the primary cause is still there. Like most commonly in diabetes, the primary cause is there. So their diabetes is still there. Their A1C is still elevated. And we know that that's related to their pain. And then secondary goals is what I said. You want to improve their mood, their sleep, their function, and their overall quality of life. And this puzzle right here, as you can see, pharmacotherapy is one piece of the puzzle. You have to consider also other issues. What's causing the pain? How, is it stress? Is it lifestyle management? Better sleep? You may even try complementary medication, education about the primary cause, and finally biofeedback. So the causes are multiple, the treatments are multiple, and the symptoms are multiple. So it can sometimes get confusing, but the most important thing is you have to think about it first. And if you don't think about the disorder, you won't be able to diagnose it. So thank you very much. And with that, I don't know if Dr. Waleed is...
Yes, I'm ready, doctor.
Welcome, Dr. Waleed. So Dr. Waleed is a neurosurgeon at SSMC Hospital. His primary interest is in movement disorders. He also is involved in education. He does have a great interest in educating both physicians and nurses, as well as spinal injuries and trauma. So without further ado, he will today talk to you about back pain, and I will log off the video so that I'm not covering the screen. Thank you.
Thank you so much, Dr. Shatila, for your highly informative lecture. I hope my voice is clear. I will start with the we will speak about back pain. We know back pain usually takes time to explain all the details, but in the general information about back pain is extremely common, and it is the second most common reason for people to seek the medical attention. After the common cold, it is the number 2 cause of loss of time at work. Low back pain accounts for 15% of all sick leaves from the work. The prognosis of most of the cases is really very good. Improvement usually occur with little or no medical intervention. More than 80% of the low back pain problems improve within a month or 6 weeks. But while the activities may need to be modified, bed rest more than 4 to 5 days may be harmful than helpful. So if the patient is coming to our clinic and he is hoping to have a sick leave for a long time, it's not recommended. Back pain usually 4 to 5 days, this is the maximum physical and mental rest. Then the patient start to regain his normal activities and go back to his normal work as soon as possible. The initial assessment usually of the back pain is going to understand the red flags. And this red flags, if we understand, everything will become very simple and very easy. I will explain the red flags in details right now, but just a brief explanation of our vertebral column, which is the main support for our body. The human vertebral column is 33 vertebrae. As we see in this photo here, we have 7 cervical, 12 thoracic, and 5 lumbar, and 5 sacral, and 4 coccyx. All this having 2 curvatures. If you look here to this brown and yellow, they are the lordotic curvatures, and we have the blue one, which is the kyphotic, and the green one also kyphotic. And this curvature develop when the child start to get raising of his head up at the age of few months, and by 1 year when he starts standing, the lordosis start to be in the lumbar region. We have to understand the balance of the vertebra. As you know, all the balance should start from the head with distribution of the body weight over the vertebral column, and then going down to the pelvis through the hip joints going to the lower limbs. So the balance should be in the sagittal and coronal. If you see the sagittal as the plumb line should be from C7 down to S1, and also the coronal should be also showing the pelvic parameters, like the pelvic incidence, which can distribute the weight from the head and from the body down to the legs. All these parameters, this is a coronal balance. It's very common to be studied, because many people, especially the children, they develop this scoliosis deformity, and we have to be careful about this. And this a classic image for the scoliosis, which can happen to children in the age of the school. And that's why we have to be careful when our students are going to the school. We have to be careful about their luggage. We have to order them not to carry this luggage on their back. I try to mix some Arabic, because I know we have some attendant people with who are Arabic speaking. هذا الانحراف بالعمود الفقري كثير الحدوث في الأطفال. أثناء الذهاب للمدارس لازم ننبه على الأطفال إن هم ما يحملوش الشنط التقيلة قوي على ظهرهم. This will make big disturbance to their back, وممكن يحصل لهم انحرافات في العمود الفقري، وخاصة في سنهم الصغير، وبعد كده بيحتاجوا للتدخل الجراحي. We will focus on the lumbar region. lumbar region هو المنطقة القطنية اللي هي بتتحمل معظم الوزن بتاع العمود الفقري ومعظم وزن الجسم، ولذلك ربنا عز وجل خلقها بتركيبة عظيمة، وسمك الفقرات فيها أكبر من باقي الفقرات اللي في الجسم. ما بين الفقرات وبعض بيبقى موجود الانترفيرتبرال ديسك، وده من أهم الشوك أبزوربر كابابيليتيز الموجودة، وبيدينا كمان منع للاحتكاك ما بين الفقرات. فاللمبر region is the lower 5 vertebrae which can tolerate the weight. This is the lumbar vertebrae here. We can see the vertebrae and the spinal cord finish at L1, and the nerve roots are coming clearly from the intervertebral foramen. And the lumbar region, there is some complex anatomy we need to explain. It's a very quick anatomy. شرح بسيط وتفصيلي للمكان ده بصورة تشريحية سريعة. This lumbar area is full of ligaments, and these ligaments can control the movement and the stability. بتحافظ على الثبات وتحافظ على الحركة بتاعت الفقرات في المنطقة ديت. والligaments دي very strong ligaments، وكمان فيها الانترفيرتبرال ديسك اللي ما بين كل 2 vertebrae، وده بيمتص الصدمات، وكمان بيوزع الوزن على الفقرات ويمنع الاحتكاك الشديد ما بينهم. The vertebrae are connected from posterior with this facet joints. الفاسد جوينت ده زي المفصلات بتاع الباب اللي جسم الفقرات ممكن يتحرك عليها. So it give us some range of movement، تدينا مجال للحركة، تقدر توطي لقدام، تقدر ترجع لورا، تقدر تلف يمين أو يسار، كل ده من على الفاسد جوينتس. عشان كده patients may develop arthritis اللي هو التهاب في المفاصل بيجي في الفقرات نفسها، وهنشرح سببه. واكيد السبب بتاعه هيبقى هو الفاسد جوينتس الموجوده في البوستيريور سبورت اوف ذا سباين. كمان هنتكلم عن الديسك. الديسك ده يعني هو الوساده او القرص اللي بين كل فقرتين، وده بيمتص الصدمات ما بين الفقرات وبعضها، وده كمان بيمنع احتكاك الفقرات، وبيحافظ على الانترفيرتيبرال فوريمن تفضل مفتوحه، اللي هي الممر اللي بيمشي فيه العصب، وبالتالي ما يحصلش اي ضغط على العصب. and the lumbar disc بيتكون من تو لايرز، اوتر لاير اللي هي الانيولس فايبروسس اللي هي ديت، والنيوكليوس اللي هي شايله كل اللود زي ما احنا شايفين كده، الاكزيال لود، الوزن اللي جاي من فوق من كل الجسم والترانك نازل على الفقرات، بيبقى ترانسميتد ثرو ذا نيوكليوس بالبوزس هير. واللي بيحمي النيوكليوس هو الفايبروس لاير القويه جدا اللي موجوده اللي هي الانيولس لاير. ده شكل للفقرات القطنيه، اللامبر فيرتبري. how it look very big and this is the intervertebral disc. ده الغضروف اللي ما بين الفقرات وبعض اللي هو البلو كولر ده. ولما تبص هنا للكروس سكشن هير تلاقي ان في الانيولس فايبروزس موجوده على الاحرف بتاعته، بتحمي جواها النيوكليوس بالبوزس اللي هي الجيلي لايك ماتيريال اللي بتعمل فيري جود شوك ابزوربر كابابيليتي، وكمان بتدي منع للفريكشن، الاحتكاك ما بين الفقرات وبعضها. ده التركيب العظيم والخلق العظيم لربنا عز وجل للانيولس فايبروزس اللي محيطه بالنيوكليوس بالبوزس في الديسك. شوف قد ايه المالتيبل لايرز، عده طبقات، وكل طبقه بدايركشن مختلف علشان يدي قوه لمنع حدوث الانزلاق ومنع خروج النيوكليوس بالبوزس فيمنع الانزلاق الغضروفي. مراحل حدوث الانزلاق الغضروفي بتبدا بان احنا ممكن ما نبقاش واخدين بالنا من اللي احنا بنعمله، بنقعد غلط مثلا، بنقعد لفترات طويله من غير ما نغير البوزيشن بتاعنا. كمان بنعمل ليفتنج لهيفي اوبجكتس وده بيبقى بصوره غير صحيحه. كمان بنحط نفسنا في بوزيشنز رونج لفترات اطول، ومع عدم اهتمامنا بممارسه الرياضه والحاجات اللي هي البريفنتيف ميجرز اللي المفروض انا هوضحها لكم حالا، بس لو ما عملناهاش بصوره منتظمه هيتغير الديسك من فوق هنا زي ما احنا شايفين نورمال وساده قويه وجميله وشوك ابزوربر كابابيليتي عاليه وعامل هايت جميل للفرتبرال فوريمن، يحصل فيه ديجنريشن. الديجنريشن ده بيجي مع الايج، يعني دايما بنشوفه above 60. unfortunately we start to see it، بدأنا نشوفهم دلوقتي في اليونج ايج بيبل، يعني حد عنده 30 و35 و40 still young بدأنا نشوف في degenerative disc disease. وده سببه ايه؟ سببه عوامل كتير جدا، اهمها ان عدد من المرضى بتوعنا مش مهتم بانه يعمل رياضه. الرياضه دي حاجه مهمه جدا، واحنا عندنا رياضه مخصصه العمود الفقري لازم نهتم بيها، اهمها ان احنا نعمل رياضه السباحه. It's very very important to practice swimming which is very important for the back pain relief, and if you have recurrent back pain it help in the treatment. تاني حاجه الووكينج من اهم الرياضات اللي بتساعد. بعدها بيجي اخر حاجه اللي هو ان احنا نمشي في البايسكل بيعمل رينج للموفمنت على بيفتح الانترفيرتبرال فوريمن، فبيخلي الممرات اللي ماشي منها الاعصاب تتحسن ويقلل الضغط عليها. يعني لما يبقى في حد عنده ديسك بالج، وده اول مرحله من مراحل الانزلاق الغضروفي انه يحصل فيه ديسك بالج او نتوء وبروز، وبعدين ديسك برولابس اللي هو الانزلاق الموجود دوت اللي ممكن يضغط على العصب. دي الستيجز اللي بيبدا بيها الانترفيرتبرال ديسك هرنيشن. اول ما بيبدا الهرنيشن من قبل ما الانيولس تبقى رابتشرد بيبقى مينلي باك بين. لو الانيولس رابتشرد والديسك ستارت تو كومبريس النيرف بيبدا باك بين ليج بين. لو انفورشنتلي الديسك طلع النيوكليوس تحركت من الانيولس ورابتشرد وبقت اكسترودد هيبقى باك بين وليج بين وهارد compression over the neural filaments, it will continue as mainly will be leg pain. دي برضو صورة توضيحية للانترفيرتبرال ديسك. هنا الباك بين categories musculoskeletal mechanical including muscle strain, muscle spasm and osteoarthritis, disc herniation, compression fracture. في inflammatory, the most common like ankylosing spondylitis. It's very common in some countries. Malignancy like bone metastasis usually بيجي الاورام في الفقرات بتيجي من اماكن زي اللنج، زي من الرئه، من البريست في السيدات، من البروستات في الرجال. Infection which is common to happen مع الاوستيومايلايتس like abscess or discitis. الريد flags which is very important when I have to see the doctor. As we said, back pain will subside soon within a time. It takes 4 to 6 weeks to subside. وجع الظهر ايا كان حتى لو شديد هيختفي ويتحسن خلال 4 ل 6 اسابيع. امتى اروح للدكتور وامتى اروح للطوارئ؟ اروح للطوارئ لو عندي علامات اسمها الريد فلاجز، والريد فلاجز دي لازم نحفظها كويس جدا. اهمها الكودا ايكواينا سندروم. This one كودا ايكواينا سندروم يعني عندك باك بين، ظهرك بيوجعك وحاسس بتنميل في السادل اريا اللي هي المنطقه اللي ما بين الفخذين، حاسس فيها بتنميل وخدلان وحاسس انها احساسها مش طبيعي، او بعد الشر حصل ان انت عندك يورين ريتنشن، احتباس في البول، او يورين انكونتيننس بلس فيكال انكونتيننس. دي علامات very alarming، لازم تتحرك مباشره من بيتك للإمرجنسي، لان ده احتماليه كودا ايكواينا سندروم. يعني ممكن يكون في رابتشر ديسك، في انزلاق غضروفي حاد وعامل كومبريشن على الثيكال ساك والنيرف روتس في الكودا ايكواينا ريجن، وده بيحتاج surgical intervention very quickly. لازم يتعمل له تدخل جراحي سريع اذا ثبت وجود الضغط على الاعصاب، وده بيحتاج خلال 24 ل 48 ساعه.
3 minutes
الريد
Dr.
فلاجز
Waleed.
الثانيه، سوري
3 minutes 3 minutes.
اوكي باقي الريد فلاجز لو في فراكتشر في اللامبر سباين، وده اللي عندهم اوستيوبوروسيس، او الناس اللي عندك بتاخد كورتيكوستيرويدز فور لونج تايم، او لو بيشنت عنده هيستوري اوف كانسر اور unintentional weight loss. كمان لو في patient عنده possibility of infection like patient has fever, patient has urinary tract infection, urinary tract infection, immunosuppression, intravenous drug abuse. All this patient has to worry about the back pain. It's not a simple back pain. These are all red flags. Causes of back pain. I give you a simple scenario. If you go to the doctor has to listen to your complaints. So you have to tell the doctor exactly your history and describe your pain in a clever way. لازم تشرح للدكتور طبيعة الألم اللي عندك والديستريبيوشن بتاعه وإزاي بيظهر عندك. ده it's mainly will help the doctor to decide quickly if you have greater trochanteric bursitis ولا hip joint pain ولا back pain which is coming from the spine. وده will help the doctor to guide you if you need investigations quickly like X-ray, like CT, like MRI, which will take us to the proper diagnosis of the back pain. The most important, we need to give some instructions to the people. Just it's support them how to take the precautions to avoid back pain and not to go for the significant changes which can take you to the difficult problems. I think better we start with exercise, swimming, bicycle, walking. These are very good to help for muscle strengthening, and also the back should be also directed to avoid some bad habits. We don't want anyone to have belt. ما حدش يروح للحزام ويقول لك انا بلبس الحزام على ظهري بيساعدني. لا، الحزام it has his side effects. ممكن يضعف الفقرات بتاعتك، ممكن يضعف العضلات بتاعتك، واللونج يوز للبريس is not recommended. This according للguidelines. كمان if we sleep we have to sleep on a medium firm mattress, not a very firm mattress, medium firm, not a very firm. We have to sleep good amount of time, like 6 hours, 8 hours. This will help the body to relax, the muscles to relax. You get up fresh and you can practice your life easily. في bad habits we have to avoid it, like lifting heavy objects. ما نرفعش حاجات تقيلة. When we are going to lift something, you have to make it close to your body and you have to bend your knee, not to bend your waist or you twist your waist. If you make the load on your back, that will be very wrong, and this high possibility to get lumbar disc rupture. Also, big important thing, stop smoking. Smoking السبب الرئيسي لحدوث الشيخوخة المبكرة في الفقرات هو التدخين، والتدخين من أسوأ العادات اللي بتؤدي لحدوث شيخوخة مبكرة في الفقرات. حد يجي عندنا نعمل له ايمج، بنصور فقراته وهو عنده 35 أو 40 سنة، we can see الفقرات شكلها شكل اللي عنده 55 60 سنة. ليه؟ لأنه he has this bad habit which is smoking. كمان هيت اور ايس. الناس بتقول نستخدم التلج ولا نستخدم الكمادات السخنه. الحل هو التلج والكولد ثينكس تستخدم لو عندك acute back pain في اول 24 ساعه ل 48 ساعه. بنستخدم التلج، بيساعد كتير جدا انك تبقى relieved من الباك بين، وبيقلل الانفلاميشن وبيعمل vasoconstriction وit helps too much. الهوت فومنتيشن او الهيت بتستخدم للكرونيك بين وافتر 48 hours من الاكيوت بين، وده بيحسن الفاسكولاريتي، بيعمل فازو دايلاتيشن، بيعمل ماسل ريلاكسيشن which is really very helpful. The final support, we have to advise the people to practice some sports in the sun. You have to see the sun. We need the sun for the vitamin D. Your body is able, yes, your body is able to give you the vitamin D in active form under the skin. So go and see the sun in the early morning, and before sunset you have the ultraviolet rays which will help you. We can go for X-ray, then CT, and the gold standard is this image, as you see, the MRI. MRI will give you all the details of your back, and the doctor can study it, can see if you have lumbar disc, which grade of disc, if any neural compression, and then he can put for you the proper treatment plan. And treatment plan will be depending on many things. We have to give an advice: control your weight, don't gain too much weight, don't bend forward, don't sit wrong positions, try to do physical therapy. Physical therapy is very helpful for muscle strengthening. Then we go for pain medications, usually analgesia, muscle relaxants, and sometimes if we have neuropathic pain, we can go for the neuropathic pain treatment. This is a brief clarification of the back pain problem. Sure, we know the back pain need detailed explanation, but thank you, Dr. Shatila, for this time. And I stop at this point, and if any questions, we are ready.
Thank you, Dr. Waleed, for the very interesting lecture.
Thank you, Dr. Waleed, and thank you, Dr. Ahmed, for two very informative and interesting lectures. We have been receiving multiple questions, both on the public chat bar and also the private chat bar that many of the patients are using. So we have 20 minutes or so, and we would like to ask a series of questions, some from patients, some from HCPs. And as we are aware, we are in an Arab-speaking country, so there will be English answers and Arabic answers. So thank you for those that will be attending. So the first question comes from a patient who is asking, they're suffering from lower back pain. They, looking online, they see a number of specialties. They've mentioned chiropractic, osteopaths, neurosurgery, or the doctors. They're confused about which specialty they should go to assess their lower back pain. What advice do you give them? Where do they start in trying to start on their journey of treatment?
Yes, I think the journey of treatment, as I said, back pain, if we don't have red flags, as we said before, the red flags of the cold equina syndrome, saddle anesthesia, or fever, or temperature, or weight loss, or the pain is coming at night and continuous at rest. If we don't have this significant pain, you can go for the general practitioner who can give you some pain medication, some rest for a few days, like 2 to 4 days maximum. And if the back pain did not subside for the coming 4 weeks, you have to seek medical advice for the neurosurgery. The most specialized people for the back pain and spine problems is the neurosurgery team. And we have a very good spine team, neurosurgeons in SSMC. And we are happy to see any patient, evaluate him, and help him in the proper management.
Yes, well, we will definitely be sending out all your details for patients after the webinar. They can see you, make an appointment. Dr. Ahmed, do you have anything to add to that? Why should a patient start their journey?
I think if someone is complaining of back pain or has back pain, a neurosurgeon, neurologist, we work together. I mean, it's left hand, right hand. So I think you can see either one of us, and we will see each other in a way. So, but see someone. I think that's the most important thing.
A question here asking, are there any specific guidelines or treatment rules, I believe this is from HCP, to follow where they can go and address and see the specific guidelines to treating neuropathic pain?
There are multiple guidelines. There's the European Federation of Neurology, the EFNS, there's the AAN guidelines, the American Academy of Neurology, there's the EAN guidelines, the European Academy of Neurology. So there are multiple guidelines on how to treat and manage back pain and neuropathic pain. So honestly, pick whatever one you would like.
Sure.
I'm American, so I tend to go with the American Academy of Neurology, but I mean, they're all good.
Thank you. We will put those links in the post-event email, so anyone wishing to follow those guidelines, they can read it in the email that we'll send out. The next question is, does the presence of cervical ribs lead to neuropathy?
Actually, yes, it can. It is not. It's actually. I don't know the incidence of cervical ribs, but cervical rib can be actually compress on your C8 nerve root, and actually can cause numbness in your fourth and fifth finger, and it can almost look like an ulnar neuropathy, and it can look like a C8 radiculopathy, but the etiology is different. Usually, your paraspinal muscles are spared, but you have signs and symptoms of a C8 radiculopathy. So yes, you can, and a simple X-ray would diagnose the cervical rib. Dr. Waleed?
Yes, cervical rib is also common to cause thoracic outlet syndrome. So if the patient is having any criteria, as Dr. Shatila said, the distribution of numbness is going to the little finger or this dermatomes of C8, and he has mild weakness in the hand or some pulse changes or some pain when he is moving the hand up like this, or pain related to the neck, I think he has to go for further investigations. We have to examine the neurological status and the vascular assessment of the thoracic outlet syndrome. Some of these patients may need surgery. So it's very important to go for thoracic outlet assessment if you are having cervical rib.
Thank you, Doctor. Dr. Waleed, there's a two-part question for you. Does the lifestyle play a role in spinal injuries? And the same person also asked that their mother and father suffer from chronic back pain. And is there any evidence of family history in terms of hereditary back pain?
Yes,
please.
Yeah. First of all, I start with the second part. We have a common syndrome in the spine. We call it cervicolumbar spondylosis, which is degenerative changes which can happen usually with age at above 60s. But nowadays we see it in young age. If we see this in young age, usually there is some hereditary factors. The patient father or mother or some of his family usually has a joints problem, like rheumatism, whatever the joints problem, plus cervicolumbar spondylosis. This can happen. The lifestyle for sure can affect the spine stability, and the spine injuries can happen because of the bad lifestyles. Like if the patient has wrong habits, they sit in a wrong position, they sit for a long time, they are not following the normal characters of their spine. We have a cervical lordosis and we have lumbar lordosis. So you have to put cushion behind your back to support the spine in the lumbar region to make it comfortable and to make it in the normal position. Also, your neck should be also in the lordotic position. So if we are wrongly putting down, looking to, like if we are using mobile phones like this or writing something on this also make a big load on the cervical spine and make friction between the spine and make further degeneration of the spine. So if we are avoiding these bad habits, we will be much better. Also, the junk food, if we are eating junk food and not interested about the healthy food and gaining more weight, this weight will be reflected on our body as a load over the spine. And this will be reflected on the lumbar and cervical region, may start degeneration early and may have some lumbar disc herniation. Also, the bad habits which happen to the children, as I said, to going to the school, carrying the bags which is heavy, full of books, and they are curved like this or looking like that or carrying this way, it's also wrong. They can develop kyphoscoliosis or scoliosis, which can progress and further need to surgical intervention. So we have to be careful about the lifestyle, which is really very important to help. Dr. Ahmed?
You said it very beautifully and eloquently. I can't top that.
Thank you, Doctor.
The next question is this person asking about their experience one-sided head pain near the temple moving towards the cheeks. Can you advise what that might be, what type of pain that might be?
Well, it's hard to say. I mean, honestly, I think you should see a neurologist with any, I mean, if you're having any type of pain, specifically in the face, or, I mean, could it be trigeminal neuralgia? Maybe could it be something else? Could it be your TMJ, with temporomandibular joint? I think it's important to get assessed by a physician because the etiologies are different and the treatments are different.
Thank you. Again, somebody asking again about your view on chiropractic treatments to resolve lower back pain, Dr. Waleed.
Yes. As I said, the physiotherapy is a great help to the management of back pain. Usually we start the patient to instruct them to avoid the bad habits and try to control the weight, then go for the physiotherapy. We have the main physiotherapy, which is depending on, they teach you the exercise, they put some training for you during their sessions, plus they use ultrasound and they have their facilities to manage the back pain. It's very, very helpful to reach with you the best muscle strengths, which can help you a strong abdominal muscles, strong back muscles. This will help you to have a healthy spine. Number two, if you have additional criteria to the physiotherapy, like acupuncture, like if you can add some facilities which make you, like some people usually like massage, like cryotherapy, and all these are types of physiotherapy which is highly beneficial, but it's not fitting all patients. The patient has to try something which is matching with his body, matching with his routine exercise, matching with his strength of muscles. So you have to respect your muscles, you have to respect your body, respect the curvatures which should be always. Then you have to adjust your position during your work, especially we are sitting long time working or typing or looking to the phones. And I feel this is a very helpful physiotherapy subtype.
Excellent. Thank you.
Thank you very much, and thank you very much for all your questions. We have a lot to get through, and we will try and get through as many of them as we can until the hour. A question here, the person is asking how they can tell between a trapped nerve and a pinched nerve. Is there any difference, and how could they tell what they have?
For intents and purposes, they're probably the same thing. Trapped and pinch are probably just different words for the same problem.
But in any case, would you recommend that they see a neurologist for that, or just the?
Definitely.
Yes.
They should see a neurologist. They may need a nerve conduction study and an EMG and electromyogram. But yes, it's a start. They should start seeing a neurologist first, and then see a neurosurgeon if there's any spine problems.
Yes.
Okay, thank you. A private question here for a patient who's experiencing on-off lower back pain for almost 4 years. Recently, it's centered on the right-hand side with on and off burning, particularly on the lower ribs. Should they be concerned, and do you advise, presumably, to see a neurologist as soon as possible?
Yes, I think this should come to the neurology clinic or neurosurgery clinic. She need good assessment, detailed examination, and we may proceed for further investigations like getting X-ray or MRI or a nerve conduction study. But first of all, she has to visit our clinic. We have to assess the patient. We have to see the power, the reflexes, the dermatomal changes if she has, type of pain, criteria of her pain, significance of her complaint, and then we proceed for the examination. Important, very important to come to our clinic.
Yeah, thank you. We're trying to raise the awareness for patients to come and see people like yourself. So thank you for that question. The next question is there any role of balloon inflated buds for disc treatment?
Balloon inflated?
Yes.
Like water beds or air beds, maybe air mattresses?
Air beds, yes.
Air mattresses.
Yes.
Yes.
I don't know of any.
Yeah, for the lumbar disc, we have a different way of management. Lumbar disc, we can proceed for microdiscectomy if we speak about the surgical intervention. The gold standard of management is the microdiscectomy, and this should go through the microscope. We make an incision, and in between the lamina, we take the lumbar disc from a small fenestration. We have another way. We can go for the lumbar disc through a different way from anterior aspect. We can open the anterior aspect through the abdomen and take the whole disc out and put another cage to replace the disc height and to maintain the height. We don't use the balloon. We have another technology. We can use the hydrocesion. This is a minimally invasive way. We make a small hole and we take like a small wire to reach the disc itself. Then this start to work with vibration to make to open the annulus and take the nucleus outside slowly. With hydrocesion, another tube also will be there. We inject water and the fragments of the disc come out. This is a minimally invasive way. It's very helpful, but it has a selected criteria. The disc should be a small disc, not big, not compressing the nerve, and going to the lateral recess. And the patient should be young. So if we have this criteria, we can go for the hydrocesion, which is maybe this what he is asking about. Otherwise, we go for microdiscectomy. We can replace the disc with a cage, not with balloon.
Thank you. A private question here from a patient who is experiencing scoliosis, but not yet any lower back pain. Are there anything preventative techniques that they can do to mitigate the onset of lower back pain due to their scoliosis?
Yes. Scoliosis is very common. First of all, we know how old is this patient. We need to know, is it a congenital or developmental, or it's acquired. The patient has to visit our clinic. We will get an X-ray. We can assess the cups angle to see how much the degree of scoliosis. Then we need to get MRI for this patient to just rule out an underlying pathology like intradural problems or congenital problems in the spinal cord. Once we assess all these parameters, we can say to the patient if he is for physiotherapy and some brace to correct this problem, or some patient, if they have significant scoliosis with high cups angle, maybe they need surgical intervention and surgical correction of this deformity. If they are having time to visit our clinic, we will be able to guide them the proper way.
Thank you. Dr. Waleed, somebody asking, how does a patient, or how do we know if they actually have neuropathic pain?
Based on symptoms, I mean, well, it's kind of what we described. For me, I'll say like the burning, the numbness, the shooting, the electrical feeling. Most patients won't come and say, I have neuropathic pain. They're going to tell you, it hurts, I have pain, and then it's the physician's job, the neurosurgeon's job is to tease out what exactly are they telling us. And that's where the history and physical is important.
I need to add something for this patients in Arabic. The description of the neuropathic pain. وصف الألم الخاص بالأعصاب اللي هو neuropathic pain بالعربي هو الألم إذا حصل تلف أو حصل ضغط مباشر على العصب. الوصف الرئيسي للإحساس اللي بيشعر به المريض هو الأساس اللي بيساعدنا في التشخيص. إنه المريض بيشعر بتنميل، يشعر بخدلان، يشعر ببرودة. بعض المرضى بتوصف النيوروباثيك بين إن هو فاير، بعض مرضى السكر يقول لك انا حاسس برمل في رجليا، في تنميل، رجليا خدلانه، رجليا فيها تلج. كل دي احاسيس للنيوروباثيك بين. في بعض النيوروباثيك بين بيجي زي الشكشكه، زي الابر pins like some people feel it like shock like، يعني زي لسعات الكهرباء. كل الانواع دي مختلفه عن النوسيسبتيف. النوسيسبتيف اللي هو الكلاسيك بين اللي احنا بنشوفه كباك بين اون ريجولار بيزس. سو لو اي حد عنده شعور بالتنميل، بالخدلان، بالبروده، بالحراره، بالفاير، بالشكشكه الدبابيس، حاسس ان رجلك فيها تنميل معظم الوقت، حاسس ان هي تقيله وعامله زي الرمل جواها، كل الاحاسيس دي اسمها neuropathic pain. If you feel it, please come to visit Dr. Shatila or our neurosurgery clinic. We will be sure helping you.
Okay, I got a couple private questions. I will start off. First one is, do supplements as B complex help with pain? The answer is, we all love the Neurobion. We routinely see patients on Neurobion with neuropathic pain, or really any type of pain. There's been no studies suggesting that complex B vitamins help, but there also no studies suggesting that they hurt. That's my point on the B complex vitamins for back pain or neuropathic. Does a leaking aortic aneurysm presenting as back pain? It's an unusual presentation. How do you suspect it in a patient?
It happens.
It happens.
Yeah, it happens. That's why I said when you go to your doctor, you have to be clear in telling your complaint significantly, and allow your doctor to inspect you quickly and palpate and examine you. Some patients who has aortic aneurysm rupture, they go to the emergency, they have abdominal pain and back pain, significant back pain. It will be associated with some pulsations in the abdomen, and it will be like dissecting pain. It's not radicular, it's completely back pain. It usually in the mind of the emergency department doctors, because they are the first line of diagnosing such a differential diagnosis of back pain. But it happens, but it's very rare. It's very rare.
One question is about antidepressants and pain. Antidepressants have been shown. Yes, we sometimes do use antidepressants. There's a lot of them, and which one to choose for the type of pain, it depends on side effect profile, the type of medication you're using. So yes, you can use it. You got to know what you're using, because you got to know the side effect profile almost as much as the antidepressant. So you got to kind of be careful a little bit about that. They're good drugs, but they can be dirty drugs as well in regards to pain management. Does tingling and a little numbness only in the legs that you need to stretch a bit in order to feel better before getting up from bed in the morning? Is it due to neuropathic pain? And any recommendations for it, please? Hard to say. I mean, it could be just tingling. I mean, everyone gets a little bit of tingling and numbness if you sit in any position for any extended period of time. If it's present only when you're waking up in the morning for a couple minutes, you can come. We would be more than happy to see you. We can do some testing. But it's really, you want to see these same symptoms throughout the day, on and off, not just in one particular circumstance what you're doing. What else? Chiropractic care, a legal standardized point of care in the UAE. It's not to mine. They're asking, is it? I don't know if it is. We don't have a chiropractic care at SSMC. We have physiotherapy and a physiatrist, and that's who we refer our patients to. Now, I don't know the evidence, and I can't comment on chiropractic care, how good or how effective they are in managing back pain. That's beyond the scope of this lecture.
Thank you, Dr. Ahmed. We have time for a couple more questions, as I know there's a very, very popular subject, and we will not have time to get through all of them, but we do have more webinars coming on pain management, so we will try and roll them over to the next series of webinars. A couple of final questions we will ask. So one question asked a number of times about the role of vitamin B12 in managing back pain. Can I have your feedback on that, please?
Yeah. Complementary treatment. Yeah. Yes, go ahead, doctor.
Well, I had just said that complex vitamins, the B vitamins, which is B1, B6, B12, B3, we give it. That's routinely in that magic pill called Neurobion that we routinely see. I mean, it doesn't hurt. The B vitamins are flushed out of your system, so they're not toxic. They don't help for neuropathic pain. They haven't been shown to help, but they haven't been shown to hurt. For back pain, I'll let Dr. Waleed mention if they do help, or does he prescribe it?
Yes, we have a complementary treatment for the back pain plus the basic management. We add some complementary. We usually try to correct vitamin D deficiencies. We try to ask the patient to get healthy food and calcium on regular basis in the in food which is rich in calcium. We add the neurotonics like B complex, like B12, and we find it helps the majority of patients. And usually, but as I said in the beginning, this is a complementary treatment. It's not the basic one. You have to have your basic medications like analgesia, muscle relaxants, physiotherapy, proper habits, and then you have to add this complementary. It make a difference. And also magnesium, which is good for the muscle activities and the muscle contraction. We add it as a complementary for the patient with back pain and muscle pain.
Thank you. And I think maybe to end on a final question, somebody asking about exercise with lower back pain. Do you recommend bicycle or walking as the most preferential form of exercise?
Number one, the best exercise for the back pain is the swimming. If there is possibility of going to swimming, it will be very helpful, especially if the person is obese or the person is having multiple joint problem. So obesity and multiple joint problem will make the swimming is the best one. Number two, walking. Walking is very helpful, especially fast walking. Walking as exercise, not walking just for waste of time. No, you have to walk as a regular exercise. This is very helpful. The third one is bike and bicycling. It's very, very helpful, especially for the old people who has spondylodegenerative changes and they have tight spinal canal. This position of bike, when you are flexing forward, it opens the foramen from posteriorly and give you a good position to avoid the neurogenic claudication. This is our sequence of the best exercise which you can start practice.
Thank you.
Thank you. And just before I hand back to Dr. Ahmed and Dr. Waleed for their final thoughts and comments, I'd like to thank SSMC and SAHA for supporting this webinar. You can find them at SSMC on the website. We will send you the address in the post-event email. You can make appointments with both Dr. Waleed and Dr. Ahmed there. Thank you to Pfizer Upjohn for supporting the event. Next week, we will have our second webinar on September 9th on diabetic neuropathy. And Dr. Ahmed will be joined by Dr. Osama Barakat from the Imperial College, who will be discussing diabetic neuropathy. So please join us for that. This webinar has been recorded and we will send you a copy of it in the post-event email. You'll be able to access it for the next 4 days. I will now hand you back to Dr. Waleed and Dr. Ahmed for their final closing thoughts. Dr. Waleed?
Yes. I really thank all the team who arranged this meeting, and they done a big effort. And thank you so much, Dr. Shatila, for guiding us for this track of a great series of webinars. As usual, you are always in the front of scientific activities and everything like that. I really thank you so much. And thanks all the team, and thanks for the audience who joined us in that simple discussion about back pain. I hope they gain some information, and I'm really very happy if someone need our help in SSMC as a back pain or neuropathic pain.
I could not say it better than what you said, Dr. Waleed. Thank you very much. I appreciate the audience for the questions, the interest. If there were any questions that we did not get to, it is only because there were so many to get to, and this just shows how much interest there is in these topics. So I thank I thank the audience for coming. I thank Dr. Waleed for giving time to give these lectures. And again, I'd like to finally thank our sponsors, both SSMC for hosting the event and Pfizer Upjohn for sponsoring it. And thank you very much. And we look forward to seeing you next week.
Thank you,
Sure.
gentlemen.
Thank
Thank you all. Good night. I'm now ending the
Thank you.
webinar.
Good night. Ma salama.
Assalam.